Raise your hand if you recognize this guy. That's President Richard Milhouse Nixon. And this was 1973 when President Nixon signed into law the HMO Act, creating the concept in the industry of managed care. It didn't exist, he created managed care, signing the HMO Act. And in 1973, I was 19 years old, and things at that point in my life were either good or bad. And that was good, unadulterated good, and it actually influenced my decision to go into medicine, to go to medical school, because I thought this was great. The concept here was give physicians some skin in the game, so to speak, in today's words. Give us skin in the game, and if we can make our patients healthier, the concept was, well, then we can get more money out of that. But if we screw up, or we neglect important things, or if we tell you to get some expensive procedure or something that is not really going to improve your health and maybe even hurt you, that would come out of our pocket to a certain degree too. So I thought that was brilliant, to line the incentives, and it excited me. It was a transformation, and I thought in a good way, of healthcare. We did great preventive work, we did great service, our patients loved us there. It was really a terrific place, and it was very profitable under this model, and I thought it was profitable because of the spectacular healthcare we did. And then this guy came in. So he was actually a patient there for a while. He drove, he was on the back of the sort of garbage trucks, dealing with the cans sometimes. So he did that, and there was a collision, and he was hospitalized, and he wouldn't stop bleeding. And it turned out that revealed that he actually had hemophilia, and nobody had known that. So this one guy with hemophilia, okay, and hemophilia, as you know, is a disease where you can't stop bleeding, and it's a pretty serious thing, except that nowadays there's actually terrific treatment for it. So we can infuse the thing that you don't have, so it's great. Well, this guy's infusions cost, remember, out of our pocket, because that's how we set this up, our little 4,000 patient office, they had to come up with a new $1 million a year to pay for his infusions. They couldn't do that, that was impossible, do the arithmetic, it's like, impossible. So if we didn't come up with another solution, they would have gone out of business for this one patient. So a couple of lessons that I got out of it. One was the way we solved it for them was we said, well, 4,000 patients is too small of a group. So we put it out on the whole group, 140,000 patients. So, a larger pool of people in a group makes a difference. It makes it more sustainable. I guess, of course, the largest group is the United States. So you turn 65, you have a choice. Do I do nothing? Do I buy a supplement? Or do I go into an Advantage program? You have a choice there. And putting the national politics aside, the choice is really individual, because a supplement comes with a premium. I pay $150 a month for myself and another $150 for my wife. I pay $25 more on top of that for a drug benefit for myself. So between the two of us, I pay about $350 a month so that I can have this important supplement and a drug benefit. I had the choice to not pay a penny. They need to make their own decision, and they need to understand that one's free sometimes, or a low premium, and one's more real. But my concern is that they're making that decision often unaware of the fact that now they have non-Medicare insurance that will say no to things, that will tell their doctor, no, we're not going to approve that, that will say, no, that's the wrong hospital. They need to know that's the decision that they're making, and it's incredibly important. And if I want a cardiologist that they say I can't go to, I'll leave, because I can, just leave it. I'll go back to Medicare and I'll pick up a supplement. Big deal. Wrong. What a lot of folks don't realize is that the law says the first year that you have Medicare, the supplement programs, if you apply for one, have to give you one. The first year that you're in Medicare, a Medicare supplement insurance company must issue you a Medicare supplement if that's what you want, and they can't ask you a single question. They can't ask you whether you've had cancer or blood pressure or anything of the sort. They just, everybody who wants one gets one, here's the price. For the first year. But after that first year, this is what CMS, this is what Medicare says. After the first year, your right to try these programs ends. And if you have not chosen a supplement in that first year, the supplement programs are no longer required to write you a policy. And if they do write you a policy, they can ask you, how's your health been? And ask you all those annoying questions, and ask you to prove those annoying questions. And then they can say, well, no, we're not going to write you a policy, or we're going to write you one, but it's going to cost 5 times what it would have cost if you. So of course the question is, well, how can these Advantage programs do that? How is it Advantage programs can do that? And it's because they have managed to get our government to profoundly overpay them. Give us Medicare patients, private industry said, and we'll do a good job and we'll be cheaper. And as a matter of fact, you can pay us 5% less than what you would pay for the same person without Advantage. For the same person in Medicare, we will accept 5% less. Okay, well, it's a good deal. They put their skin in the game, money where their mouth is. Okay, so Medicare Advantage got started. And then within about a year, the industry came back to the government and said, nobody warned us. These people are sick. They're expensive. And they actually negotiated for that 5% discount to be turned into an 8% overpayment. Otherwise, they are overpaid, and by being overpaid, that is how they can have no premiums, and that's how they can throw in these, really inexpensive options. And then here we are, happily holding up the bottom of the chart. Despite spending twice as much as those countries spend in general, we're at the bottom of that chart. You knew that before I came in. What you probably didn't know is this. What happens when we turn 65?
Get better.
It gets phenomenally better. Not just a weeny bit better, phenomenally better. So year by year, country by country, we climb our way to the top of the world. Year by year, we migrate to becoming the lowest mortality rate, the best remaining life expectancy in the world, abruptly at the Medicare age. So there's all of us, right? And then there's all the stuff we want, doctors and hospitals and such. And in between us, of course, is the money. And the money today is managed by all these payers. The United States government is a payer. That's the state of Missouri, schools in Missouri. Sorry, you have to put up with Missouri. It's the price of having here. Insurance companies. So this is complicated. This is incredibly complicated. Each one of us has our own contracts with one or more of those things, and then each of those things has their own contracts with each of these things. It's a mess. It's really complicated. And complexity, if you're into industrial restructuring, complexity is the enemy of quality. If you want to improve, if Toyota wants to make a better car, they know the most important strategy is to simplify their workflow. Complexity is the opposite. Needless complexity is the opposite of quality. It's expensive, and there's all these gaps as a consequence. So instead of this uniquely American solution, we have another uniquely American solution to propose, which is this. Just make it one, right? Single payer. So that's what a single payer means, and there's a number of things we should work on, one of which is to improve the benefit, is to deal with these finances that make people have to buy a supplement or go into an Advantage program. So the first thing is eliminate the copays and deductibles. So for the most part, we say that. When we say improve Medicare for all, people say, well, I still have to have a supplement. No, you don't. No, you don't, because we're saying get rid of the copays and deductibles. And I'll show you the economics momentarily. So that's the first major thing about improving Medicare. The second major thing in my mind about improving Medicare is make the benefits more comprehensive. Medicare today does not cover dentistry. I'll bet you don't run into that. Medicare does not cover dentistry. It doesn't cover eyeglasses, hearing aids, and there's a list of about 15 of these things that Medicare should cover and that Americans actually agree would be a good use of our tax dollars. So improve the benefits and get rid of the copays and deductibles. There's other things, but that's the two biggest things in my mind about improving Medicare. You hear people say, improved Medicare for all. That's what we largely mean. And then expand it, give it to everybody, give it to Congress, give it to school boards, give it to everybody in the country, give it to kids. If you gave it to kids, then you wouldn't have to have these fights every few years about whether or not we're going to expand children's health insurance program. Give it to kids. Give it to old folks, well, they have it. Give people in the middle. Give it to the very wealthy. Give it to the very low income. If you give it to the lower income groups, then you don't have to have these fights about whether or not we're going to expand Medicaid and all that stuff. So it turns out that this has been actually quite well studied. There have been, that I've been able to find, 29 studies that have looked at the economics of this. And every one, or 32 actually, every one of these 29 have said that of course there's new costs, but there's new savings. And that the new savings are at least as big, and most say bigger than the new costs. What are the more tangible savings? First, we would have obvious savings in system administration. One program instead of hundreds of programs. There would be obvious savings there. That's one estimate. We would be able to negotiate the prices of drugs. So this number is assuming a 40% reduction of the 15% we spend. So 40% times 15% we spend means the country would reduce overall healthcare spend by 6%. So And 40% reduction is not getting us down to world pricing. So it's not like, a crazy high estimate. So that's what that number says. There would be uniform rates in hospitals. Today hospitals can sometimes charge literally 10 times as much for one patient and for another patient, not based on quality or sickness, just based on what they can get away with. So one fair price, and of course then some more work on fraud and abuse. So you're probably, hopefully, realizing that these new savings don't actually fund a program, right? So how do you actually fund the program? This is the nasty 3-letter word or 5-letter word, taxes. So the first question, and I'm going to show you a model for that, the first question is, well, how much do you need? How much would this program cost? Can we put some numbers on this? Can we put some numbers on this? So, okay, yeah, we can actually. So here's what we spent in 2017 as a country, all told. We spent $3.25 trillion. Okay, but what's that going to mean under the new program? Well, we need more than that, right? We need 3.6 trillion for the increased usage, people doing stuff, but we need to reduce that by the savings. So the bogey that's roughly in a lot of these studies, not everyone, but a lot of studies uses this number, and I've got a source for this particular one. So I want you to, so the number we want to hit is funding $2.93 trillion. Now look at those two numbers there, the 3.2 trillion and the two, that's what, 331 billion? This is a government that has shut itself down over 5 billion. This is 331 billion. The health insurance companies today have no incentive to fix these things at all. They don't. Insurance companies know that they have 20 to 25% annual turnover in membership. They know that if you're a member of their insurance company today, chances are 2 or 3 years from now, you'll be in a different insurance company. And they know that. So when I go in there as a naive, happy doctor saying, well, let's make people healthier, they say, okay, but you got to make them healthier within 3 years. So a campaign for colonoscopies, that takes 10 years to pay off. Campaign to improve housing, to deal with food deserts, to clean the air up, all of these important social determinants of health, they don't care about that. They don't care at all about that. But if you put in a single-payer national Medicare for all solution, all of a sudden, it's actually, the government saves money by doing that. The government would put you through a little quiz. Do you want apple pie? Raise your hand if you like apple pie. Okay, not everybody does. What if I told you that it was really tasty apple pie, really good apple pie, it was homemade, and we'll even, for you, we'll toss in ice cream. Okay, so surveys have shown us that people love tasty, delicious, ice cream-coated, homemade apple pie, right? That's what the survey
flaky crust.
With flaky, oh, so I would actually want to raise my hand if you said it's my wife's apple pie, because she's like the best apple pie maker in the known universe. And anyway, so there's that. Now, those of you who like apple pie, raise your hand again. What if I were to tell you that apple pie causes obesity and diabetes? Do you still want some apple pie?
Yes.
Yeah, what the hell? What if I told you that it would cause a heart attack? Do you still want apple pie? What if I told you this apple pie had poison in it? What if I told you this apple pie cost $5,000 per slice? I want poisoned apple pie for $5,000 per slice. Where do I get some? Turns out you probably can't. Okay, so the way we ask the question determines your answer. That's my point. So there are surveys about how popular is Medicare for all. And the easy ones say it's really, really popular, right? So what if we told you Medicare for all would guarantee health insurance as a right? What if we told you that? Sign me up, I want that. Okay, what if we told you it would eliminate premiums and reduce out-of-pocket costs? Most people say, yeah, that's pretty good, I like that. All right, those are the easy ones. What if we told you Medicare for all would eliminate private insurance companies?
Woohoo!
Yeah. You're in that tiny minority. This is really important to understand. You're in that tiny minority, and this is a perfect thing for our opposition to use when they say Medicare for all. That sounds just lovely, but did you know that means no more private insurance companies? Oh, no, I didn't know that. If they had asked the question, it'll eliminate private insurance companies, but you wouldn't need them because you would have a program that's even better than what you've got today. It's a different question, right? It's a different question. That's not the question. So on Fox News's, there's proof, that when people understand what Medicare for All is, and that it means no more private insurance, you're going to lose your private insurance, they say no. What if we told you that it would raise taxes for most Americans? You like Medicare for All, but it means your taxes are going to go up? Well, what if they said it's going to raise your taxes, but less than you're going to save by not paying a premium, not paying a copay, not paying a deductible? Well, then it's one pocket. You take my premium or take my taxes, it's still my pocket. But that's not the question. The question was, well, once Americans knew that Medicare for All meant taxes go up or that private insurance goes away, and there's another one, I think. What if they told you that it would threaten the Medicare program? You're not going to have the same Medicare that you have today. You're not going to have Medicare Advantage. That subsidy that you were careful to pick out, or that supplement that you were careful to pick out, so if you ask that question, yeah, it's threatening Medicare today because it's going to add dentistry. It's going to improve it. You're not going to need, but so the question is, and I'm telling you, people are getting these questions. What if we told you Medicare for All was going to mean that you have to wait a lot longer for tests and things?
Yeah.
So that was just, that one isn't misleading. That's just completely wrong. There's an abundance of evidence that says that there's no reason to think that. We could go deeper on that if you want, but that's just wrong. So my point is, you need to be armed with that because the news media and the insurance industry is attacking us with this kind of misleading but accurate poll. The poll's not from a discredited source. The poll is not, from from the John Birch Society. The poll was done by the Kaiser Family Foundation, whom I have enormous respect for. But these are accurate questions. And there's another set of questions that are more robust in the way that you would think, that are different results. So so be aware of that. When you hear these things, it's somewhat misleading. There are two bills in the House, or in Congress, in the legislature. There's a bill in the House by Representative Jayapal, and there's a bill in the Senate by Bernie Sanders. And they have more in common than they have that separates them. So they both have comprehensive coverage for all residents in the United States. Neither of these two bills says for all citizens. They say for all residents.
Yeah.
Now that doesn't mean that you would run across the border from Canada and suddenly have American health care. Doesn't mean that, because the both laws also say that the Department of Health and Human Services would be able to put in language around that and put in some constraints and define it, because the regulations are, don't forget about regulations after you get a legislation passed. The regulatory fight is where we often lose the progress that we made. So there would be regulations defining that, but in general, not citizens necessarily, including residents. And we want that, right? They pay taxes and they get sick. And if I get my tuberculosis from somebody who's got a passport or somebody who doesn't have a passport, I still have tuberculosis. We want them, and we're not going to, somebody who's not a documented, whatever the right language is, citizen here, when they go to the emergency room, our country is not one that's quite yet so cold-hearted that we're going to say, well, I'm sorry, we're not going to treat you. We let the non-citizens die over there. We don't do that yet. So we're taking people, we're giving health care to people at their most expensive phase, and that's imprudent. If you're willing to say, go out there and die, well, I can't help you. But if you're not at that point, then let's stop wasting our money that much, and let's buy the diabetes treatments. Let's cover them for the preventive stuff and all this other stuff. So it's important to cover residents, not citizens necessarily, beyond citizens, for economic reasons, if for no other moral reasons, for economic reasons. They also are all similar in that they cover virtually every doctor and hospital. There's none of this Medicare Advantage mumbo jumbo. You could go to any doctor, any hospital. You could obviously therefore change jobs and not worry about, oh, well, I want to go to that job over there. It's a much better career opportunity, but they have this other insurance. And if I change to that job, that means I have to change insurances, which means I have to change doctors, and I kind of like my doctor. Or I have to go to that other hospital, which I guess isn't an issue here. So you can change jobs. You could actually work where you wanted to work, and none of these plans have any premiums or pretty much any co-pays and stuff. But they differ. So the bill in the House, 1384, has the same benefits as Medicare Plus. It covers all of these other things. It covers all this other really important stuff. The bill in the Senate, 1129, just released a few days ago, one of the bigger differences is it doesn't cover long-term care in the same way by putting it into Medicare. Instead, it preserves this little funky part of Medicaid, which is half state funded, half federally funded, and long-term care is managed that way. So it would retain a lot of the variability, and I think it would just make more sense to put it into Medicare, have what the states spend on Medicaid today go into the finance pool, and then you'd have the same long-term care benefits in Alabama as you would in Alaska, as you would in California and Missouri. So I think that's a shortcoming of the Senate bill, but it's not a fault of the MAP shortcoming. The House bill has a 2-year transition, the Senate bill has a 4-year transition. I'm going to unpack that more. And the Senate bill permits Medicare Advantage to continue during that 4-year transition. So cost sharing, there's no premiums or copays in the House, and for some reason Bernie's committed to having having a copay on pharmacy. And if you don't feel a personal human obligation to end human suffering and to do what you can to help people, I feel sorry for you. So that's how I answer that question. And I think we should kind of move away from our own little talking circle. So here's the books, Moral Politics. He's got an easier to read book, Moral Politics. Have you read Moral Politics? It's dense. It's like, this thick. It's an interesting book. The first half is all the stuff that we just talked about in an apolitical, nonpartisan way. Then the second half is all about why conservatives are wrong and liberals are right. But it's so you can read the first half, and I've given it to many anyway. So that's the second book there about elephants is much easier to read, much shorter, and with different but additional insights. Strangers in Their Own Land I talked about, Moral Tribes we talked about, and the TED Talks book. I don't want to forget that. It's a good book. Any more?